Good morning, everyone, or good afternoon, depending where you are in the world at the moment. Welcome to today's panel on how mobility systems in sub-Saharan Africa are meeting the public health challenges posed by COVID-19. My name is Monette Zard. I'm the director of the program on forced migration and health in the Heilbronn Department of Population and Family Health at Columbia University. Today's discussion is being held to mark the release of a policy brief published by the Migration Policy Institute and the Program on Forced Migration and Health on mobility systems and public health in sub-Saharan Africa, drawing on a series of conversations with public health and migration practitioners over the last year, as the continent, in common with the rest of the world, grappled with the challenges of COVID-19. So as we all know, the pandemic has severely disrupted migration and mobility, both globally and across sub-Saharan Africa. In early 2020, many governments in the region moved quickly to close their borders and impose travel restrictions to control the spread of infection, substantially curbing, although not entirely halting, movement on the continent. This quick and decisive action at a time when community spread had yet to occur, has been credited by many with limiting the spread of COVID-19 on the continent. However, the mobility shutdown also caught many unawares, with hundreds of thousands of migrants left stranded across the region and impacting those whose livelihoods rely on cross-border trade or travel. As governments have tried to respond to the pandemic and restart mobility, the African continent has been able to build on its experiences with battling Ebola and other infectious diseases, and to leverage some of its past investments in regional integration with bodies such as the African Centers for Disease Control, ECOWAS, and the East African Community, providing really important platforms for fostering coordinated action. But gaps remain. A consistent theme that has emerged in the research has been the need for much more dialogue and coordination across the public health and migration fields at nearly every level, from the local, national on up. And public health measures have also been unevenly applied across the region, reflecting weak border management, weak public health infrastructure. And there's also increasing concern about the knock-on impacts, the indirect impacts of managing COVID-19, in particular on managing other diseases of concern for the continent, like HIV and TB and so on. So I think in the final analysis, an over-reliance on mobility restrictions and border closures as the sort of public health tool of choice has really exacerbated and compounded the economic disruption caused by the pandemic, not just in sub-Saharan Africa, it must be said, but globally as well. So we have a really distinguished panel today that is going to help us explore some of the strengths and weaknesses of current responses on the continent, and really to help us begin to learn some lessons from the last year. Our first speaker today is Dr. San Lau, who is a pediatric doctor and senior program officer for the Care and Protection of Children Learning Network, the CPC Learning Network at Columbia University's Mailman School of Public Health. Prior to joining Columbia, San worked in children's hospitals in Australia and researched the molecular biology of childhood brain tumors at Children's National Hospital in Washington, D.C. Our second speaker is Kate Hooper, a policy analyst with MPI's international program, where she primarily works on the Transatlantic Council on Migration. Her research areas include labor migration, migration and development, and refugee and immigrant integration policies, with a focus on Europe and North America. She holds a master's degree from the University of Chicago's Committee on International Relations and a BA in history from the University of Oxford. San and Kate will both reflect and present on some of the findings of the policy brief itself. And then we're fortunate to have with us two distinguished discussants. First, we'll have Professor Joseph Kofi Teye, who is the director of the Center for Migration Studies at the University of Ghana. He is also co-director of the UKRI South-South Migration, Inequality and Development Hub. He is a geographer by training and was the lead migration expert for the development of national migration and national labor migration policies in various African countries, including Ghana, Sierra Leone, Malawi, Zimbabwe, and Zambia. And then finally, we have Michela Martini, a senior migration health regional specialist for the Eastern Horn of Africa at the International Organization for Migration's regional office in Nairobi. Michela entered the UN system in 2000 and has served in Eastern Europe, the Middle East, and is currently obviously in East Africa. In her current position, she provides technical assistance to IOM country offices, as well as governments across the region in strengthening universal health coverage and health services for migrants and host communities, and strengthening core capacities around the IHR, the International Health Regulations, including for outbreaks response and achieving the SDG goals. Both Michela and Joseph will share some reflections based on their own experiences as scholars and practitioners working in public health and migration in East and West Africa, respectively. And if all goes according to plan, we should have about 20 minutes at the end for audience questions, where we'll be using the Q&A box. So do please be inputting your questions into that Q&A box as our speakers make their presentations. But without further ado now, I'm going to hand over to San.
Thank you, Monette. It's a pleasure to be a part of this important discussion, and I also want to thank my fellow panelists, MPI, the team organising this event, and GIZ and BMZ for their support. I'll be briefly highlighting some of the findings from the policy brief, focusing on the public health challenges that COVID-19 presents for mobility systems and the response in sub-Saharan Africa. Next slide, please. The global toll of COVID-19 currently stands at more than 170 million confirmed cases and more than 3.5 million deaths. The disease has profoundly altered the mobility and migration landscape in sub-Saharan Africa and around the world. To understand the challenges that COVID-19 poses to mobility systems, we need to first look at SARS-CoV-2, the virus that causes COVID-19. SARS-CoV-2 is a coronavirus related to the coronaviruses that caused the SARS pandemic in 2002 and the MERS outbreak in 2012. And like these viruses, it's believed to spread mainly through respiratory droplets when people are in close contact. While SARS-CoV-2 is not as deadly as some other viral diseases, including SARS, MERS, or Ebola, it is generally more transmissible and spreads easily in community settings. This has contributed to its rapid spread and the large number of cases and deaths globally. SARS-CoV-2 often spreads silently, which makes it difficult to contain from a mobility perspective. Studies suggest that more than half of COVID-19 cases are transmitted by people without any symptoms due to pre-symptomatic or asymptomatic infection. Because of this, public health tools such as temperature checks at borders and symptom-based health screening and isolation are less effective for controlling COVID-19. And further complicating the picture, from late 2020, concerns about emerging SARS-CoV-2 variants triggered a new wave of border closures and travel restrictions around the world. The World Health Organization has identified 4 variants of concern, first detected in the United Kingdom, South Africa, Brazil, and India. We are still learning about these strains, but early evidence indicates that these variants are more transmissible, driving higher case rates and hospitalizations, and can cause more severe disease than the original coronavirus found in China. Concerns about variants have complicated the public health response, including the vaccine rollout across the African continent. And next slide, please. Moving on to my second point, I want to emphasize that COVID-19 is one of myriad challenges facing national health systems in sub-Saharan Africa. Many countries in the region have fragile health systems and acute shortages of healthcare workers and specialists, as well as intensive care unit beds, ventilators, oxygen, and other resources critical for the COVID-19 response. Even before COVID-19 arrived in the region in early 2020, these health systems were strained by population health needs and endemic diseases. For example, the Democratic Republic of the Congo has battled simultaneous outbreaks of COVID-19, measles, and Ebola amidst continuing conflict. In addition, COVID-19 testing in several countries in sub-Saharan Africa diverted resources from important TB testing programs. And we know that these disruptions to essential health services can result in illnesses and deaths from other diseases that exceed the toll from the pandemic itself. When the WHO declared COVID-19 a public health emergency of international concern in January 2020, just 2 countries in Africa had the ability to test for SARS-CoV-2. At the end of the year, testing capacity was still uneven, with 10 countries accounting for more than 2/3 of the tests conducted on the continent. More recently, COVID-19 vaccines are a promising new tool that can help to curb the pandemic and to facilitate migration. Yet 85% of COVID-19 vaccine doses administered worldwide had been given to high and upper middle income countries, while low income countries have received just 0.3% of the global share. Africa's COVID-19 vaccination rate is lower than any other continent, despite efforts by the COVAX Global Vaccine Facility, the Africa Union, and national leaders to expand vaccine access. On a positive note, as Monette mentioned, several countries in sub-Saharan Africa leveraged their experience dealing with past infectious disease outbreaks, such as the Ebola epidemic, to swiftly activate emergency response plans and adopt public health prevention measures early on in the pandemic. Next slide, please. I want to end by headlining some of the key recommendations from the policy brief. My colleague Kate will elaborate on the first point, which calls for greater coordination and communication between migration and public health actors. We also recommend strengthening the public health response with a migration lens and paying particular attention to migration routes and the health and protection needs of mobile populations. It's also vital to include migrants and refugees in COVID-19 prevention, preparedness and response plans, including national vaccine campaigns. We also recommend strengthening national health systems so they are better equipped to respond to COVID-19 and other population health needs. This will require increased capacity for COVID-19 testing, genomic sequencing, vaccine supply chains, contact tracing, treatment, quarantine, and isolation, as well as investments in health infrastructure, public health surveillance, capacity building, and human resources. Finally, meaningful engagement of communities that send and receive migrants is crucial for an effective COVID-19 response. For example, IOM is doing great work in this area with the Migrants as Messengers network. I'll end here because I know time is short and I'm really looking forward to learning more from the other speakers and hearing their perspectives. Thank you.
Thanks so much, San. Kate, right over to you. Next part.
Thank you so much, Monette, and thank you, San, for that excellent overview. I'd first just really like to thank both San and Monette for this collaboration on our policy brief. It's been a real pleasure working with you, as well as our funders, GIZ and BMZ, for their support both for this brief and for their support for our broader research series with MPI, which looks at critical governance issues in a changed world. So I will take over from San and talk about some of the key takeaways on migration management from our policy brief. Monette has already alluded to how COVID-19 has really upended migration and mobility in sub-Saharan Africa. By about June 2020, most countries in the region had suspended international flights, and a majority had also closed their land and sea borders. These measures didn't fully seal borders, but they did lead to a significant drop in numbers detected crossing borders. And of course, this illustrates some of the trade-offs between a public health response and a migration response. Moving quickly to close borders and restrict travel in this way bought governments some time to prepare for the pandemic, but it also led to significant disruptions to cross-border trade, services, and travel. We saw many people get stranded in other countries as borders closed, and travel options became either impossible or simply unaffordable for most people. At the same time, others were prevented from moving in the first place, whether that's for work or to access protection, or they were forced to use more indirect or dangerous routes in order to avoid detection. So there are lots of knock-on effects, even resulting from this public health response. Since summer of last year, we've seen some of these measures be lifted. So in most countries, international flights have since restarted, and some but not all land borders have reopened. So there's been a bit of a shift away from closing borders completely or restricting travel in favor of making entry conditional on meeting certain public health requirements, such as a negative COVID-19 test result. So over the last year or 18 months, we've seen public health measures being rolled out really along the migration continuum. And so to give you some examples here, some of these measures are happening pre-departure, so before someone starts their journey. This can include things like sharing accurate information about travel restrictions or the latest health requirements, both through official sources like government websites and through outreach to local communities and migrants. So San's example of migrants as messengers is one example there. Another example of pre-departure health screenings. So this can range from asking travelers to fill in a questionnaire stating that they don't have COVID-19 symptoms, or obtaining a negative COVID-19 test result before they depart. And this is required currently by many countries in the region, as well as outside of the region as well. Some of these measures are also happening at the border. So closing borders is an obvious extreme example of this. We've seen many of these border closures be rolled back, but concerns about new variants and the potential spread of COVID-19 has led to some new travel restrictions being introduced. But another example of border measures is health screenings and testing requirements that take place at the border. So this might, for example, be requiring someone to take a COVID-19 test when they arrive rather than just before. But of course, rolling out these requirements can be really logistically challenging, especially when you're talking about very busy border crossings. And then another set of interventions can happen after the border. So this can include contact tracing, so making sure that new arrivals give their information so they can be contacted in case of further outbreaks, or requiring new arrivals to quarantine, whether that's in a private residence or in a designated facility. So this range of public health measures has helped restart some mobility, but at the same time, the slower reopening of land borders and the new costs associated with travel, so things like covering that expense of a COVID-19 test or covering the costs of quarantine, can render travel unaffordable or impractical for many travelers. So there is, a potential sort of growing gulf between those who are able to afford to travel and those who aren't and thus can't, follow these new rules. So opportunities for cross-border travel currently remain rather uneven. But it's likely that these public health requirements are going to remain the status quo, at least for now. I think experience really tells us that security measures for travel tend to be quite sticky and they're rarely rolled back. So I think that we should assume that some of these measures are likely to be the new normal, at least for the foreseeable future. And so finally, to pick up on San's point about the need for greater coordination, I think that the pandemic has really illustrated the limits of unilateral action against a disease that doesn't recognize national borders. And it's really sort of illustrated how coordination is key for minimizing disruptions, but also for sort of creating more nuanced policies around public health and migration. So things like avoiding sudden border closures that can leave people stranded, but also, for example, working together to phase in new testing requirements to ensure that there's sufficient capacity on both sides of the border. To date, most of this cooperation has happened either at the bilateral level or the regional level. We've seen that some regional economic communities step in to play a growing role here on things like harmonization and information sharing, and even starting to develop common standards around things like the cost of COVID-19 tests. This cooperation is slow. It takes time to get everyone on board and build that capacity, but it's a promising sign. While it's all currently geared towards the current crisis, this can lay the groundwork for future cooperation, both on public health issues and also managing migration more broadly. And I'll stop there and hand it back to Monette.
Wonderful. Thank you so much, Kate. Thank you, Sam, for laying out so succinctly some of the main findings of the brief. Just an encouragement to our audience, please do input any questions that you have into the Q&A box so that we can be sure to ask them of our panelists at the end. But I'm going to pass over now to our two commentators, beginning with Professor Teye, to share some reflections on their own experiences, in this case in West Africa, over the last year, looking at mobility and public health, and of course, any reflections on some of the findings of this piece of research that they feel they'd like to share. So Joseph, over to you.
Thank you so much for the invitation. I would like to thank all the organizers for inviting me to reflect on managing mobility and public health in the context of the COVID-19 pandemic, especially with specific reference to the West African region. I also like to, at this time, congratulate the authors for such a comprehensive and well-written policy brief. The findings perfectly reflect the situation in the West African region. As we are all aware, migration in West Africa is mixed, and it includes refugees and then economic migrants as well. And even though media narratives tend to suggest an exodus from Africa to Europe, a majority, in fact, the latest assessment shows about 72% of migrants from West Africa are actually in destinations within the region. There's also a high level of internal and intra-regional migration. A lot of people move across the borders for work, maybe in the agriculture sector, and also as traders. So the intra-regional mobility in West Africa, as we are aware, is facilitated by the ECOWAS Free Movement Protocol. That was passed as early as 1979. And then when we experienced the situation of COVID in March 2020 in West Africa, restrictions were imposed to deal with the COVID. And these restrictions have varied effects on mobility and livelihoods in the region. And the situation is consistent with what has been noted in the brief for the rest of Africa. First, as part of measures to control the spread of the disease, many of the West African countries imposed the restrictions on even internal mobility. So we saw lockdowns that came in by mid of March. And then a number of the countries also closed their international borders, especially starting from mid of March. And as eloquently expressed by the earlier speakers, these things were justified at the time because of the lack of capacity. So the lack of capacity in the health sector was even more pronounced in the West African region. As you are aware, many of the countries are among the poorest of the poor in the region. And these restrictions actually affected economic activities, both internal migrants and international migrants. In fact, some assessments we carried out shows that remittances from internal migrants, largely in the urban areas towards the rural areas, declined. And the closure of the borders also affected livelihoods of those who depend on cross-border economic activities. So Ghana-Togo border, for instance, if you are talking about that, Sierra Leone, Guinea, Nigeria, Benin, these are borders that are characterized by a lot of cross-border movement. And so all these people are not able to do. Meanwhile, at the same time, a lot of West Africans were stranded at the borders, so they are not able to move. So the ECOWAS protocols were literally suspended. Those that tried to cross through the porous borders, some of them were even deported. So Ghana, for instance, some people from Guinea that crossed to Ghana, they were deported. Now, the situation as far as the measures to manage the COVID-19 migration are concerned is also consistent with what the policy brief has discussed very well. And so you realize that a number of things were put in place by various West African countries. And so the pre-departure interventions, as argued for the whole of Africa, it was the same thing. The capacity to test was very low. They tried to improve it in some of the countries. But then if you look at the testing capacity, it's still very bad. vaccinations are still very low, and vulnerable migrants may not have access to some of these things. There are also problems with managing health issues at the border because of poor health infrastructure at the borders. The post-entry interventions, as was reported in the brief, is the same. In fact, there are several challenges with contact tracing. Access to health services is also very poor in many West African countries. We have poor address systems, so even to track those that have come in is a little bit difficult. It's difficult. In fact, in Ghana, for example, where we try to track people that have come in within a particular week, because of fears that a lot of people would have come with the disease, it was difficult to track people because the address system they give at the airports were not really correct. Then also, we also have effects on livelihoods, as we have seen already. Also, the gaps that we identify are applicable to West Africa. Migrants were not actively involved in some of the programs that were designed. In fact, when they were even going to do lockdowns, a lot of the internal intra-regional migrants were not aware of this. It took them by surprise. Migrants also did not have access to testing equipment. Social distancing is difficult in the slums. And then also when it comes to even treatment, it's so difficult for migrants. Now, when you look at the packages that were also designed even to support people that are whose economic activities have been affected by the disease, it did not really consider immigrants that are poor or internal migrants that are very poor, because, for instance, your business should have been registered before you have access to the stimulus packages, and most of these migrant businesses are not registered. So the recommendations made are perfect, and we help in a long way to deal with the problems in the West African region, especially the need to collaborate among countries. That is very important. As the borders are still closed, the land borders are closed, even though the airports have been reopened, and many migrants can still not cross the borders. It will be important for the countries in the region to collaborate to find ways of reopening these land borders. And then also the need to incorporate migration into the design and implementation of COVID-19 programs are also important. This is something that is applicable, and I think that will have to be done in the West African region. And then also they need to put in place mechanisms to facilitate safe return. A lot of West Africans were stranded in other countries, some in the Gulf states, some within the region, because we have no comprehensive mechanisms to bring people back home. And I think this is a call on us to do some of these things. And then last but one, it will also be important that when you are dealing with issues of international migration, we should also focus on the informal sector. And when we are dealing with even internal migration, there's a need to focus on the informal sector. A lot of migrants internally and internationally are working in the informal sector, and the programs designed are not targeting them. So if you look at all the stimulus packages, they are not targeting people in the informal sector. You have to register your business, as we have said. So they have to look at these things. And then finally, there will also be a need to ensure that informal settlements are enhanced or are equipped with proper health infrastructure, because a lot of the people in the informal sectors settlements did not have access to even COVID-19 testing facilities, and this will have to be done. So to conclude, if West African countries follow many of the nice recommendations that are made, it will help us to improve the management of migration and COVID-19, and also improve our ability to manage future pandemics. Thank you so much.
Thank you so much, Joseph. That's a real insight squeezed into 7 minutes. I really appreciate that. So we've heard the situation in West Africa, and now we're going to zoom over to the other side of the continent, East Africa. Michela, could you share, as a public health practitioner, what you think some of the issues and experiences are that we can learn from the last year's experience with the pandemic? Over to you.
Thank you. Thanks also for the invitation, and congratulations for the policy brief, which I read with a lot of interest. And I could not agree more with the recommendation. It's something that came into my mind is whatever method of approach we are taking to investigate the migration and health, we reach with the same and similar conclusion and recommendation. So meaning that we really know the gap, we know the way forward, but I think the biggest challenge in our area is how to translate those recommendations into practices and into real policy, how we can assist our member states to make this intellectual shift. But the biggest challenge is that we are dealing with two titanic sectors, migration and health, which by nature are different. We are talking about a public health which is structured, indicator driven, which are clear, measurable, and based on inclusion. While we are looking at migration, especially in the recent policy on migration, we are looking at more toward exclusion concept, and even the definition of migrants is not yet universally recognized. So the two platforms, they speak different languages, and this is one of the biggest challenge that is translating the reality that health aspects often remain marginal in migration governance platform, and vice versa. As public health, I can see the migrants are always considered as a minority. Human mobility is considered like an area at the marginal side, and the two platforms, they may talk only in exceptional case, like during the emergency, but they still speak different languages. And this is why we have seen also, we have been impacted in Eastern Horn of Africa by migration policy and direction that had impacted the public health. For instance, forced return of migrants under the umbrella of the COVID threat has definitely impacted the public health response of COVID in many countries that had to deal with thousands of returnees to be under quarantine, case management for COVID, testing, etc. And they were not ready for it. And so those migrants, they were only left under the assistance of development partners. And something that we should consider, that in an area, in the period where we have reached the highest number of international migrants, 281 million, in Africa has the highest intracontinental migration. We have reached more than 26 million of international migrants in Africa. And in Horn of Africa, we have more or less, we host 6.5 million of international migrants. We are referring to a large population size that in public health is relevant. So this narrative needs to be changed, and the population movement need to be integrated in a more systematic and long-term approach in the public health of the African countries. So we are in the moment where we need to switch from the emergency approach to health system strengthening. And I think the current dialogue also on the universal health coverage can represent an opportunity. However, in majority of the countries, migrants are still left out of the current discussion. So the progressive inclusion of migrants into universal health coverage, it can represent a threat to the achievement of the SDG for African countries, and we need to start working now in parallel, and especially partnership with financing institutions to make it happen, maybe in the next 10 years, whatever, but the dialogue is now. We see that COVID has been really a case study for us and has confirmed how migrants were excluded by the National Plan of Preparedness and Response. As a consequence, as I mentioned before, thousands of returnees, but also thousands of migrants that were on routes to go in other countries, they remain stranded with no assistance. As IOM, we have supported the response, even from livelihood, accommodation, but also quarantine site, testing, etc. But this is what, because the preparedness response plan, they were not ready to receive this target. This target was totally undermined. So there is the immediate need to have a revision, the preparedness plan, and to be ready for the next epidemic if it's going to happen, not to make the same mistake. But something that is a bit worrying this moment in the region, but also I believe in many countries in Africa, is the vaccination, because the current vaccination plan in many countries, they are quite unclear for eligibility of migrants. This means they are not excluded, but they are not neither included. So basically it's going to be difficult to reach them to see if they are eligible for vaccination. And of course, excluding migrants for vaccination means excluding large population and leaving the epidemic underground. And this is an advocacy process that we are doing as IOM with other partners. We have to include migrants, especially undocumented migrants and migrants working in a formal sector eligible for vaccination. I want to focus on one of the recommendations, which is really a lesson learned during COVID. And this is the one focusing on cross-border health surveillance. There is the need that the surveillance be expanded with understanding more the mobility, human mobility, indeed. And this was already stated in 2016 during the global review of the International Health Regulation, and the committee was clear with 3 recommendations: start collecting data on human mobility, working with the related agency like IOM, UNHCR, but also with an important principle to go beyond the point of entry and looking at the mobility continuous of the border, especially in Africa, with 80% of cross-border movement to the neighboring countries, and often through ground crossing and sometimes through unofficial ground crossing. This concept of the border need to be revised and expanded. And this should be part of the health system reform, how to incorporate this mobility. As IOM, we have developed a health border mobility framework that can serve the purpose. Is a framework that is able to prioritize the ground crossing in relation to the size of population, topology, behavior, etc. But this tool has been used during the Ebola, during the COVID, but we need to include this approach as health system strengthening, to be systematically conducted and not only in the emergency. I want to get close to my conclusion, emphasizing the momentum and how the public health can strengthen the impact on the migration governance. The implementation of the Global Compact for Safe, Orderly, and Regular Migration that was agreed in December 2018 makes an important contribution to merge the 2 sectors. In the Global Compact on Migration, Article 15 is specifically focusing on improving access to health services and meeting the demand for health professionals. So there is the health component, and there are many synergies. And because of the Global Compact on Migration and to support member states, because it is member states-led platform, IOM is the secretariat, there are many platforms ongoing. And sometimes I see that the public health experts, they are not involved or engaged in this migration framework. For instance, there are 4 UN migration network in Africa, covering Southern, East, and West and North Africa, with related work plan. And the new thematic approach is the inclusion of migrants in the COVID response and recovery efforts. So we need the public health helping them. There are regional consultative process led by Regional Economic Commission in Eastern Horn of Africa, is led by IGAD, and it's going to happen this month. There are thematic stakeholders consultation for Africa, and all of those platforms, they will convene in July, the 12th and the 13th, for the intergovernmental regional review of the Global Compact on Migration. This month, the 22nd, there is the stakeholders consultation for the thematic area 3, which incorporated the health. So this is the moment where we need to expand the public health portfolio within migration governance. At country level, there are UN network, there are migration coordination forum, but what I see from my experience, sometimes the health sector is a bit weak and not well informed. As a result, 3 countries in my region, they have submitted the Global Compact for Migration report, and the health component is still very weak comparing on what they are actually doing. So, and there are many other dialogue and platform on migration. So I think that my point is that we need to have the health partner taking the responsibility to engage more and incorporate the health aspect in the core migration governance platform, because the sector is there, is structured. And as development partner, we need to assist the member states. So we need to inform, to train the health expert, because they may not be informed and prepared. Migration and health, we know it's a new discipline, even if it's not recognized as discipline yet. But there is the responsibility of also supporting with training and generating capacity also on migration and health expert in Africa. I will stop here, giving the time also for questions and answer. Thank you.
Thank you. Thank you so much, Michela. I mean, such an interesting set of reflections, and you captured our lives so clearly when you talked about the distinct language and disciplines in the migration sphere versus public health. You know, I, with my colleagues, sit in a program in a public health school focused on migration. And that is something we navigate every day. So even something as simple as talking about public health surveillance, which is a standard tool in public health, when you use the term surveillance in the context of migration, has a very different connotation and is received in a very different way. So a really interesting sort of set of insights, both at a macro and a micro level. So colleagues, please do ask some questions. I see we already have some questions coming into the Q&A. I would like to start off with a couple of them and add in my own. One of the issues that I think has been sort of spotlighted by all of our speakers has been this question of recognizing the realities of how migration occurs and thinking about the informal sector, thinking about the limitations of sort of traditional contact tracing methods. So, you know, one of my questions to the panelists, perhaps beginning with Joseph, is whether you have seen any interesting initiatives that are community-based, migrant-based, that would, you know, transcend sort of our traditional understanding of how contact tracing should occur, how public health surveillance should occur, but that really is embedded in communities themselves. Have you seen any examples of how that might work coming out of the region, of communities either being approached by governments or by intergovernmental organizations or taking the initiative themselves to think about how to monitor the spread of the COVID-19 within their contexts? And that is one question that I would like to pose to you all, because I'm genuinely interested in what you have seen. But I would like to add on to that a question that's come in the Q&A box, which flags, the reality that the same ethnic groups are often spread over multiple countries in Africa. And the question is, in the context of COVID-19, in what ways are these existing realities being incorporated into cross-border coordination on migration, mobility, and public health? So it layers on the sort of family ties to that informal trading system that exists across very porous borders in Africa, and how that gets accommodated in our public health sort of realities. So Joseph, over to you, and then I'll open it up to see if any other panelists would like to respond.
So thank you so much. So I will try to quickly or briefly talk about both questions briefly. So the first one with the contact tracing. So the traditional contact tracing, as can be done in the developed world where you have address systems, is something that is not working in Africa. So in Ghana, what we have done, what our health systems have done, which I think is innovative, is to rely on what the people we call assembly members in the locality. So once they mention somebody's name in the contact tracing, the contact tracers work with traditional chiefs and assemblymen. And so if it's a migrant community, the names are mentioned and people in the locality, because the address system is not working. So if you just come to my area and you are looking for Joseph Teye, there could be 2 or 3 Teyes. And so they just try to, people in the locality help to identify the houses where those people live. Sometimes it has led to people being identified and they say, no, they were not the actual people because they are similar names, so there were challenges. But it was obviously a better approach than trying to use the addresses, because address system doesn't even exist. Sometimes they have relied on phone numbers, and that has been very useful. Mobile phone numbers, especially if they know the mobile phone, they try to call for the person to say where they are rather than try to use the address system. Then the second question on the ethnic groups, I think that is the more reason why I like your recommendation on intra-country coordination. So if we take Ghana, for instance, we have people from Togo and people from Ghana, and some of them have just their uncles at the other side. Remember, West Africa was partitioned largely in the colonial era. They use our health system. Some of our people also use the Togolese health systems. So even if you are talking about a simple thing like even testing or vaccination, if you place it at the Togo border, Ghanaians will go there. If you place it at the Ghana border, Togolese will go there. If you don't coordinate it very well, it's going to lead to tensions. Now the border closures don't work because people are moving every day. It's just fluid. He has his farm at the other side. So the current border closures are not working because people are just crossing and the borders are porous. So it's the more reason why your recommendation that we need to coordinate, that will be very useful. Because without coordination, there's going to be a lot of tension, just for the main reason that ethnic groups spread all over and across the borders. So that is something simple I can say. Thank you.
Thank you. Thank you. Anyone else would like to chime in?
I can add something for to answer. I can top up something from Professor Teye.
Please.
Well, contact tracing, I do agree, of course, the role of the community is critical when we are dealing with migrants. We have, actually, we run a primary healthcare clinic in urban area of Nairobi, and we do contact tracing for tuberculosis, and we have done for COVID as well. An important element, the clinic is free of charge and not discriminatory, means we don't ask ID document. This is the experience after 15 years to run this clinic, especially to have the right answer when we do contact tracing, is building the trust. It takes years for us to have the trust of the community that could approach the health facility because majority are undocumented. Because of course the challenge is always when we are dealing with fragile and migrants in a regular situation or informal situation. And this is why the key element is building the trust and be non-discriminatory. During COVID, what we have noticed also, of course, with the fear to be not only detained because they were irregular migrants, but the fear to be put in quarantine discourage friends to disclose other name, of course, because being quarantine means be out of work, etc. So not having a living for that. So contact tracing was extremely complicated during COVID. Even the national authority, Ministry of Health, they struggle with the national population for the same reason. So in this case, poverty, lack of access of formal work from both national and migrants have really impacted the contact tracing. But for cross-border, one of the experience that we have had in a few years ago and is still ongoing is the activation of cross-border committee, especially at local level. In many cases, they were useful to trace also the TB patient for follow-up or treatment and care. So we are moving already in the health system strengthening, so not focusing only in an emergency or outbreaks response, but also continuity of care. So the cross-border coordination is extremely important. And I do agree with the recommendation that this should be a priority, because this was a gap during the COVID response also. For instance, certification of COVID tests that were not recognized across the border. And this has created, for instance, a congestion at some of the border for the truck drivers. So there was not an harmonization at the regional level. And this is extremely, should be put as a priority. In terms of ethnic group, this is very challenging question. And what we consider when we are dealing with human mobility, that there are different layers of observation and analysis. The first one is identify the number of people crossing, where they are going, not only the city, the town, but where in the town, in the market and the school, etc. So this is capturing the movement. And the second layer is also who they are. And this is it merge with the ethnic, or this is also means gender, children. And the third layer is the social behavior of those population. So there are different layers when we are approaching human mobility, which is not simple numbers. In certain cases, be the same ethnic group, it helps because crossing the border, they can simply approach the health facility, they speak the same languages, so they have less barrier. In other settings, it can be instead a reason of conflict because of competitiveness of the health services of facility. So this is a very quite sensitive, broader area to be discussed, definitely.
Very, very interesting, and just really highlights the importance of a context in carving out your policy and your approach in this area. For example, in the United States, one of the big requests on the advocacy side is the need for very, very clear firewalls between, sort of immigration and public health, really ensuring that whatever information is gathered from a public health perspective, is not shared for immigration enforcement purposes. And I think that's, as a general rule of thumb, a very good one. And in different contexts, as we've heard, migrants face a different kind of reception. Communities that are part of one family, that have generations of experience going back and forth, and in other contexts, communities that are, in various ways, in conflict. And so really, I think important to think about the nuance here. We have another question that came in through the Q&A about what the role for local authorities might be in promoting inclusive approaches to mobility and public health. And by local, I think we're really thinking about city and sort of subnational levels of governance. And I think it would be great to hear from any of our panelists as to whether we've seen sort of how that level of governance has played into these issues. Of course, migration is managed quintessentially at a national level. So it would be interesting to hear what we've seen at these sort of lower levels of governance in terms of inclusive approaches. I also wanted to add one question for our panelists, which is how to perhaps tease out a little bit more how issues of refugee and asylum are playing out when it comes to the border measures that we have seen put in place to respond to the pandemic. Are there exceptions being made for refugees and asylum seekers on the continent? Are there humanitarian corridors being created? And how that particular set of vulnerable group within the migrant community is being dealt with. So let's start with the question about local authorities. I am happy to take whoever wants to put their hand up. I have a tendency to look to my right at Professor Teye and see what in the Ghanaian context has been the experience, but do feel free to jump in, any colleagues.
Yeah, so I'll briefly, in the interest of time, answer that and quickly say something about the refugees thing so that we save time.
Yeah.
So the first one in the inclusion of the local authorities, that is very important in the Ghanaian context for two reasons. Even before we come to including the other groups, one issue that came out during the management of the COVID was even how to receive migrants in some communities. You know, the initial thinking was that international immigrants were carriers of the COVID, because initially many of the people that came in were international immigrants. And so in some communities, when they see somebody who is not in their community, the youth will go and attack. There were cases where people were attacked in some parts of West Africa, and traditional authorities have to be engaged to put a stop to that. Even some people who were living in urban areas that decided to go back to their own rural areas. In the past, where my immigrants were welcome, now some were seen as carriers, and traditional authorities have to set in. Now, when it comes to engaging the migrants and engaging them in the programs that are designed, the traditional authorities are very important, because remember, as you have outlined in your recommendations, most of the time this has to do with lack of information. Migrants sometimes don't have even the information about, if you are talking about behavioral testing facilities that are available, or even measures that are going to be taken. And you need to depend on the local authorities to engage them better. So if you want to share information with the migrant communities, the local authorities there are sometimes in Ghana, we have traditional systems of sending information, public address system, where somebody is sent around to go around and to shout, to announce it. And these things are controlled by the traditional authorities. Remember, because in the villages, it's not everybody that has a radio or a television. So without the local authorities, there is no way you are going to get the public health information clearly to the migrant. Even if you are going to deal with issues about COVID and maybe where people should go and where people should not go, and borders that are being closed and others, so people are not stranded at the borders, you still need to depend on the traditional authorities to carry such information to the migrant. This was not well done during the COVID time, which is why IOM has documented the number of migrants that were stranded at the border, because they didn't get the information and they were already local. Now, when it comes to the last question on the refugees and whether humanitarian corridors were established, the answer is no. It wasn't something that was comprehensively done. Most of the time, UNHCR and IOM sometimes have to appeal to some West African governments, for instance, to help some refugees or asylum seekers to be able to pass through. Sometimes the information at the grassroots level was not the best. So border officials will say they are waiting for a command somewhere before they are able to pass. So that is one of the things that the coordination you talk about in your recommendation that I like so much, we have to tackle, because that was not done. The other aspect of this was that as a result of the COVID, the former channels of migration were sort of closed in a way, because some of the countries where even proper labor migration agreements exist. For instance, people moving to the Gulf states and others. Some of the embassies were not working or are still not working. They are not allowing, they are suspended those things, and people still want to move. So trafficking is increasing and a lot of things are increasing. Remember, at the same time, refugees are finding it more difficult to cross because sometimes when it's here, we have to approach the government. So more will need to be done in this area to coordinate it, to create the humanitarian corridors. They are not really existent now, and more will need to be done on those things. Thank you.
Thank you so much. So we are at time, but I'm going to give the opportunity for sort of last thoughts from Michela, Kate, or San, just a last sentence or two to sort of share reflections on those two questions, if you'd like to. Michela, over to you. Just very briefly, please.
On my side, I think maybe we have reached the momentum that for Africa, really we are advocating as IOM to have member states joining to develop a migration and health framework with priority and principle to agree, because it has been done globally, but it's not African oriented. So I really think because as soon as we can have a framework, we can help at country level going toward the same direction. And this is as a first priority to help countries to include migration variable in the public health information systems, because we don't have data.
Right. San, over to you.
Thank you. So I just wanted to end with the thought that sub-Saharan Africa does face many challenges, but there are also so many strengths in the area. And just to go back to the earlier question about community-led initiatives, one of the strengths of the COVID-19 response in Africa has been a strong foundation of community health workers. So there was one program in Nigeria where community health workers who were delivering polio immunizations quickly pivoted to respond to COVID-19 by providing COVID-19 health education and contact tracing. And yeah, I thought that's an excellent example of communities filling gaps and addressing their own community's needs.
Thanks, San. An important reminder. Kate.
I think in the interest of time, I'll cede my time back to you, Monette.
Okay, wonderful. Well, what can I say? Thank you all for really helping us surface many, many questions, some really interesting strategies as well that have emerged from the work in sub-Saharan Africa over the last year that I think actually can be useful globally in thinking about how we navigate some of the challenges around mobility and public health. I think this is really the start of a conversation. There's a lot of work to do, and we really hope that this brief helps surface some of the questions and point some ways forward for the public health and migration communities to take this work forward. So a big, big thank you to our wonderful speakers, Dr. Lau, Kate Hooper, Dr. Teye, Michela Martini, really for sharing in such a generous way your thoughtful comments today. We're so, so grateful. Thank you very much, and see you on a Zoom soon.
Thank you. Bye.
Bye, everyone.
Bye-bye.
Bye.